A very good morning, ladies and gentlemen, and welcome to yet another CPD program organized by the Society for Health Research and Innovation Academy. Today's topic is an interesting one. We are going to talk about the common injuries in rugby, and our resource person today is Dr. Rangana Hettige. Dr. Rangana Hettige is a consultant in sports and exercise medicine at Teaching Hospital Peradeniya. He has extensive experience as a team physician for A Division School and Accredited Institute of Sport and Exercise Medicine in Cape Town, where he worked with national as well as club level rugby teams and earned a level 3 certification in immediate care in rugby. His clinical interests include on-field sports injury management, concussion care, and athletic rehabilitation, with an emphasis on Hettige currently serves as the secretary of the Sri Lanka Sports Medicine Association. Good morning and welcome, sir, to today's session.
Good morning, everyone. And thank you very much, Sri, for inviting me for this, giving me this great opportunity. And also, I would like to thank all the participants who are coming on Sunday for seeing me talking on your holiday. So I'll start my lecture, and it is all about the rugby. First of all, we have to know what is rugby. Like we are seeing players are been seen players and in the TV or everywhere in the YouTube, you see how they are playing. But when it comes to rugby, there are several areas that we have to know. First thing is in the Sri Lanka, we are playing the rugby union code. So likewise, there are rugby league. According to the rugby league, they have only 13 players and they have separate kind of rules and regulations. And other than that, we have fast rugby like rugby sevens, and also it comes with tens rugby, also para athlete rugby. And nowadays they are more concentrate on up to several decades ago. It's all about they didn't care anything about the weights, but now they consider about the weight as well. So mainly I will talk about the rugby union code, and that is what happening in Sri Lanka. So I will more focus on 15 game, so we can have any idea about it. When we take the rugby, it is a 15-player game, and it's having 10 bench strength, so altogether 25 players. Unlike in other sports, usually the all 25 has to be participated. Everyone is giving maximum during the game time. And it is contact and combat game. Yes, brutal game. It's having so much of contact and force transferring. A lot of things are happening. And the beauty of the rugby is it is having a different body types. No one should no one should be similar. According to the position, you have a separate set of weight and agility and the height. Everything is different. So when patient comes to you, you should have a basic idea of whether he's playing the forward or in the midsection or in the back. And most important thing, the rugby is the only sport having the contact without protectors. So it's having high energy game. All the other sport you have to use the safety mechanisms, but even in rugby, even you can't take a plastic pieces into the ground. So high injury rate. When we talk about that, important thing is if you have a good technique, once you are having the professional level, competitive level, less injuries. As we are covering the matches, when even in the Sri Lankan international level, very much less injuries. But when you covering the lesser divisions, so many injuries. So first thing is play should have a good technique. Few years back, up to few years back, rugby is having a lot of concussion, head injuries, neck injuries. So because of that, they have decided to reduce the tackle area. Now the tackle area is below your armpit and above your knee level. So they reduce the tackling area that has reduced a greater level of injuries. Right. So this is kind of all classification we are using when it comes to the sport. Likewise, in all the sports having two arms, like you have to move, you have to give your force. So when we take the rugby, according to this graph, it has put on the mid level. It means it's having moderate level of dynamic component, but having the moderate level of static component. Yeah, there's a problem with this classification because it's depending on the sport. Like I say, when we take the 15 rugby, there are two types. One is fast open rugby, other one is contact rugby. So teams like New Zealand, they're having a more dynamic component. Team like uh, England and South Africa, they are more towards the static component. So there is a dynamic changes in between. Usually we categorize in mid dynamic component and mid static component. Right. As you can see, the world champions, different body types, having tummy, um, lack of physics, taller guys, shorter guys. Everyone is playing. That's the beauty of the game. And you have to know which place that they are playing. Right. So in this lecture, since we have less time, I can't cover all the injuries in detail. So I have identified few important sport injuries, and as a primary care physicians, how can we manage those to help to the sport? Right. When we take the rugby, we can divide it into acute and the chronic. The reason is the players on the ground is the tip of the iceberg. More time they are spending on the gym and the ground before come to the play. So gym component you can't see. They are doing a lot of gym training, lifting. So more chronic injuries. Uh, same like as the acute injuries. So in this lecture, I would like to cover mostly the acute part because with the because of the time constraint. Right. So when we take the areas, we have most injuries happening in the lower limb, uh, like 30 to 50%. Then head is the other part, upper limb, and the trunk. So we will talk about each areas and important areas to be discussed. Right. First thing is head. So when we take the head, anything like road traffic accident, anything can happen during this game. So laceration, head injury, neck injury, eye injury, especially foreign body, and sinister cases like retinal detachment. So eye injuries are mainly happening during the scrum. Illegally, some are doing the eye gouging. So that kind of injuries are also there. And the ear, especially period auricular hematoma, is more common in the forward pack because they are head-to-head scrum. So there's friction happening in the ear. So there will be a periauricular hematoma and nasal fracture and the nasal bleeding. And when we take the mouth, lip laceration and the dental injuries. In the game of rugby, with the injury they can play, but you have to restrict the bleeding. Once you restrict the bleeding, you can come back into the game to until the restriction of the bleeding. The medical staff can take him away for for up to 5 minutes. Then, if it is not settling, they have to do the substitute. Right. From head injuries, I will talk about the concussion mainly. So, as you are working in the hospital level, concussion is not a significant things according to the our level. Like we are more focused on traumatic brain injury. But concussion we are taking as a mild traumatic brain injury. So according to concussion, it is a traumatically induced transient disturbance in the brain function without anatomical changes. It means that when you take the CT, it would be normal. If you take the normal MRI, that would be normal. So, but he's having some symptoms. Then we are putting them as a concussion. Usually in the hospital setting, what we see is During the head injury observation, we are observed after the 24 hours. If doesn't progressing or worsening, we are discharging the patient. Rugby, it is different. So once you clear of having a sinister blade injury, then we are putting him the code called concussion. Then we are starting the management. So as you all know, when somebody is having a concussion, you will lose your higher brain function. It means your analytical capacity, your things about the whereabouts, and also your memory, and also your emotions. So all things will be disrupted. So those are things we are using to identify symptoms, especially at the ground level. Usually they will complain of the head injury and the concussive symptoms, but once they go home also, they can come with the symptoms. So as a primary care physician, if if player comes to you after 1 or 2 days complaining of headache or vomiting, feeling of dizziness, please suspicious about having a concussion. Right? How to manage from there? First thing is you have to assess the symptoms. Now, all over the world, we are using Scott 6 assessment tool. Unfortunately, for that assessment, it will take around 30 to 40 minutes. At our level, I don't think practically, unless you have to attend to that particular patient in the clinic setup or you are in the private practice, I don't think assessment of the Scott 6 is not practical because it takes a lot of time. So, but what you can do is identify these domains like cognitive impairment, somatic impairments, mood differences, and the vestibular and visual alterations, especially the sleep. And what you have to do is you have to exclude severe symptoms like if he comes to you with a severe headache, then you have to be alert. And somebody comes with a neurological deficit, you have to be alert. Somebody is having the vomiting, yes, you have to be alert. When we take the adults, we are allowed up to 2 times of vomiting. After the 2 times, if still the persistent symptoms, we are advised to go to the hospital for exclude brain injury. In the children, we are taking as 3 times and the pupil reaction. So cover this all the domains, right? Uh, you can search question called the MEDEP questions. There are some 60 questions. Then out of that, they will cover this all the cognitive, somatic, and mood, sleep, all the parts. Right? How to manage? First thing is do not mask the symptoms. If somebody comes to you after the game and complaining of the headache, please you can give paracetamol if it is indicated, but don't go for the higher painkillers or the sedatives. You will mask the symptoms and he will be in the great trouble. And other thing is advice on cognitive rest. This is the important thing. In initial 24 hours only, we are uh, advising on absolute rest. So you can't use any devices. You don't need to study. You should not go outside. You have to stay in a little bit of dark area. Be quiet and under someone's supervision. That is for initial 24 to 40 hours, depending on the scenario. After that, don't advise them to have a prolonged rest. If you stay with the prolonged rest, symptom will be not resolving with the time and it will worse the condition. So you have to get him into the society. Right? So after 24 hours, we encourage them to start the physical exertion with light cardio like the walking and the jogging. Then we are going for the sprinting. Then for the lifting exercise, initially high ranges. Then we are going to the high weights. Then starting sport specific drills and the contact session initially with the cushions, then with the players. During this, if those symptoms comes back, you have to go to the previous level, stay there for 24 hours, then start up again. Once he ready, please assess the psychological analysis, because once it happen, he will get fear to go for the team. If he's not psychologically fit, he will have another attack. So please avoid that. You have to get assess whether he's psychological fit. Then we are putting him to the ground. Then after the concussion, once everything is happened, so we are, if he's boy who's under the 18 years, usually we are keeping for 3 weeks according to the World Rugby regulations. If he's adult, he can come to the ground in 10 to 14 days time. Right. Then I move to the shoulder joint. In the shoulder joint, the main areas that I want to emphasize is clavicle injury and the shoulder dislocation. We'll talk about that. Right. Clavicle fracture. Clavicle fracture is one of the commonest injury during the rugby because of the contact. Mostly happening when player is having the direct contact or he is fallen onto the ground without support. First thing is we have to identify whether he is having surgical indication or not. Usually what we take this as guidance, but this is not 100%, but you can take this as a guidance. If there is a displacement more than 2 centimeter and the shortening more than 2 centimeter, skin tethering and neurovascular involvement, and also about the sport. If the player is a high caliber player who's depending on his contact, and if he's having a very important match in the future, yes, even with the mild fracture, we may go to do the fixation to come let him to come to the ground quickly. So it's depend on the condition. Right. How we are managing clavicle fracture as a primary physicians, right? First thing, pain management. In our practice, since you can give the pain to at least for 5 to 7 days to reduce the pain, it is very important. And we are using the clavicle brace. In the sport arena, we are encouraged to use the figure of 8 clavicle brace. Then you have to use the physiotherapy modalities. You have to use it wisely, because in the acute stage, you have to use the TENS machine. But when it is subacute level, then you can use the ultrasound, not on the bone, surrounding area. Then you have to plan the rehabilitation program, because if the player is having an injury to the right arm, you can't allow him to lose his conditioning in the lower limbs, other arms, back, and everything. So if he's having a injury, please do not ask him to have the complete rest. You have to make the program to him to keep his fitness level. After 2 weeks, after 2 to 3 weeks, you can take the X-ray and see whether the healing process is starting and whether if there's any malalignment. If not, you can keep it there. Usually healing will be happening in 4 to 6 weeks time, but even though it is healing, he is not fit for the contact games. At least it will take 3 to 4 months to heal properly to have gained the strength. So during this time, you have to make a good plan. All right. As you can see here, we are encourage them to use a shoulder pad when they are recovering. If you can't afford for the shoulder pads, we ask them to have the shoulder taping. Right. So I'm going to the shoulder dislocation. Shoulder dislocation is one of the commonest in here in the rugby arena. So it's management difference with the age. It means that if a younger player like he in his 80s and the 25 less than 35 years, if he having a first dislocation, there's a risk of have another recurrent dislocations. If the player is more than 35 years, 35 to 45, Usually one dislocation doesn't mean he's having the recurrent dislocation. So depending the age, we have to manage. And with the player position. In the rugby, not like in the cricket, we have less throwing above your shoulder level. So when we decide in the surgery options, we have to see what kind of a player he is, right? And if somebody uh, having a fallen onto the ground on the fallen on outstretched hand, then he will have a traumatic shoulder instability. We call the TARS, traumatic shoulder instability, which lead to shoulder dislocation. It can be direct or indirect. And in the rugby, we usually in the normal population, we are seeing anterior dislocation of the shoulder. But in the rugby, because of the way they are playing, posterior dislocation also very common. So when the rugby player comes to you, always think whether it is the anterior dislocation or the posterior dislocation, because anterior dislocation we can identify without any problem, but posterior dislocation is very difficult to identify. When the player is muscular, you can't see any changes. Only thing that you can see from the x-rays. So be careful when the rugby player comes to you with the shoulder pain. Right. So if somebody is having the first dislocation, ideally you have to do the reduction at the hospital setup, but we can try once. If it is not went spontaneously, don't try to do several times in the first dislocation. Send for the hospital to take the prior x-ray under the anesthesia and the sedation. You can do the reduction. Even in the first dislocation, if you are planning to do the reduction, please take the decision immediately, because after the 1 to 2 minutes, the muscle getting tighter, then you can't uh, move around shoulder for the relocation. So please consider about the time. Right. In the some players having the recurrent dislocation, they will immediately put by themselves. So even ideally, you have to take the post reduction X-ray to check whether there's any problem. There are several methods of reducing the shoulder dislocation. So I just mentioned here with the time constraint, I will move to the next slide. Right. Shoulder dislocation is happen. So how to manage this patient? There are two options. One is the surgical management, other one is the non-surgical management. Even in the non-surgical management, it's depend on the whether he's in the season or in the off season. So it is like this. Players start up their tournament. Usually our rugby season is lasted for 4 to 6 months. One player is having a shoulder dislocation for the first time during the first match, right? Then if we correctly rehabilitated, he can come to the uh, team in 6 week time, 6 to 8 weeks time. But if we go for the surgical options, prehabilitation, investigation, and the waiting list, and after that post rehabilitation, everything will be take around 6 months. He will miss entire season. So depending on the season place, we are deciding whether to go for the non-surgical or the surgical options. In the surgical options, as I said before, we have different options like arthroscopic repair and the Latajet and the remplissage, depending on the condition, right? Depending on the condition. Usually in the rugby players, we would they don't need overhead movements a lot. Like the cricketers may need arthroscopic repair because he can have a good range of motion. But when you do something like Latajet procedure, your abduction and the external rotation is little bit restricted, but it is very how it's called, like very stable. So we would discussing with the orthopedic surgeon, we have to decide which kind of surgical procedure is good for the player. Right. I told you if somebody is having a shoulder dislocation in the first match, our target is bring him to the ground in within 1 month or 6 weeks. Not like cricket. Cricket, if body is a fast ball or anyone is having the shoulder dislocation, if we rehabilitate, it will take 3 months. But rugby, it is less than that. That's why I told you it's depending on the sport you are playing. Right. Um, During the first phase, after the shoulder dislocation, you are seeing the patient. First thing is you have to pain medications, and you have to immobilize your shoulder in a sling, usually for 2 weeks. You have to keep the ice until the swelling and the pain is settled. Avoid abduction and the external rotation during these 2 weeks time. The most important thing about the shoulder dislocation, avoidance of abduction and the external rotation, and gradually introduce according to the range of motion. We can The problem after the shoulder dislocation is dislocation happening in the capsule, but there are muscle like deltoids and the rotator cuff muscles. All the muscle will be get wasted if you are not using it. For to prevent that, we are encouraged to do isometric exercises even during this recovery time. This is the most important part, I think, as a doctor. Just for the completeness, I will show you how we are managing. Then after 2 weeks, we are removing the sling. Then increase the range of motion by the Codman exercises. That same thing that we prescribe in the frozen shoulder. Then we have to go with the passive exercise, active assisted, and active and the resistant exercise. That is the process that we have to go. And initially, you have to start with closed chain exercise, then the open chain exercise. Sorry about the, I can't describe you in detail on these particular words and everything because of the time constraint. Yeah, you have any questions or anything, we'll discuss it later. Right. After that, this is the above third phase. So we are planning him to play, say, sending into the ground in a few weeks' time. Then only we are starting the strengthening part. So not only the strengthening of the shoulder, we have to increase the proprioception, agility, speed, everything, and the functional exercise depending on the player and the position. Then after phase 4, we are going for the plyometrics contacts, and after 6 weeks, we are sending him to the ground. Once the season is over, we will do the MRI to confirm how much of the damage, then discuss with the orthopedic surgeon to do the relevant surgery for him to get ready for next season. So that is how our management is happening. That's why I take a bit of time for this to give you a basic idea how we are managing the players in the team session. Right. So next one is the acromioclavicular joint injury. Uh, Actually, I have done this lecture in the 3 years back. So just to memorize it, I just included this here. Right. Which is very common injury, acromioclavicular joint injury, because of the contact and the falling, and because the players having the ball on their hand, they can't lose it. If you lose the ball, you will giving the balls to the other team. So because of that, players are fallen with the ball, then direct hit of your shoulder. That is why most of the acromioclavicular joint injuries are happening in the rugby. Right. So we are using the Rockwood classifications. There are 5, 6 types, but most important for us is like up to 3 level. Up to 3, we are managing non-surgically. After 4, 5, 6, depending on the condition also, we are deciding whether to go for the surgery. So as a rule, as a guideline, you can say 1, 2, 3, no surgery. 4, you have to decide. 5, 6, you can take the orthopedic opinion on surgical management. Right. How to manage initially as a primary care physician or the team physician? First, reduce the pain. you can give pain management, and you have to keep the ice. uh, Putting ice, I will bit describe about how to keep the properly ice on the injuries, like initial 24 hours. If the if the injury is happening today, up to go to sleep, you can keep the ice every 2 hours up to sleeping. You can keep 10 to 20 minutes. Never keep the ice on the bare ice, and you have to cover it with the polythene. Then do not wake the player to keep the ice. You are doing more harm. So just ask him to have a good sleep. Next day onwards, 4 hourly up to 74 hours. Then 3 times. Then depending on the condition, you can kill a 1 time or the 2 times. All right. Activity modification, like the acromioclavicular joint problem is, if the joint is not functioning well, our shoulder is giving uh, gravity weight on the joint, so it will widen. So we have to remove this gravity problem. That is why we are using the sling. So for the grade 1 and 2, we are using the broad arm sling just to keep it up. And if it is a grade 3, we will use the, because support is not there in the shoulder AC joint per se. So we are using the sling and plus AC joint taping, that showing in this picture. Above 4, we have to refer. Right. Then I'm going to the lower limb. To cover up about the muscle injury, all the time I talk about the joints. Now I go to the hamstring injuries, just to give you the idea about how to manage a muscle injury. Hamstring is one of the very important muscle, because a lot of injuries happening and a lot of protocols and everything is developing around the hamstring. Still, even in the uh, top top notch level, the state of art facilities even couldn't reduce hamstring uh, injuries, recurrent injuries. So we have to know what kind of injuries it is. As we all know, hamstring having three muscles, like bicep femoris and the semitendinosus and the semimembranosus. Right? It's covering two joints, the hip joint and the ankle joint, and you have to know the bit of the anatomy before attending that. So two type of injury. One is the sprinting type. When you are running the 100 meter. It can happen initially when you starting or at the finishing level. Second one is stretching type, like when you are using gymnastic kind of a thing. The type 1 injuries are more symptomatic, but it will heal quickly. Type 2 injuries are less problematic, but it will take a lot of time to heal. So you have to have the idea about that. Injury classification is very complex in hamstring because it's having three muscles. It's having muscle belly, it's having central tendon, it's having musculotendinous junction, and also tendon insertion and the avulsion. So simple classification you can't have an idea. So when you're describing, you have to mention everything separately. For just because of the muscle injury, you can grade it 1 to 3. But as a sport physician, we are using MRI based classification like the BAMIC classification. So I don't think we have to go to up to that level. You have to know type 1 is 25%, type 2 is above 50, type 3 is like almost like 100%, 75 to 100%. Right. The problem with the hamstring injury is, once you having the hamstring problem, unless it is severe, you can walk in 2 days' time. The pain will be settled in 1 week time. So you feel normal, but the muscle is not ready for the game. So if you started it like that, it will having the re-injury. The high recurrence rate, like even in the developed country, it is still around 50% to 70%. So you have to manage very carefully. Right. Sport physician, as a primary physician, how to manage a muscle injury or the hamstring injury. First is the price protocol. Is the protection, uh, relative rest, keeping the ice, compression, and the elevation. Right. How to protect? We are using thigh guard and tight short. So we are recommended to wear tight short around at least for 10 to 12 hours per day, at least for 1 week to give a good compression. And you can use the commercially available tie guard as well. Then we can keep the eyes. Then we have to start the mobility. So that's the difference between the muscle and the joints. So in the muscles, you should not rest. We had that concept in those days, but now what we say is, if you rest the muscle fiber alignment when it is healing is crisscrossing, reducing its power. When you move with the restricted, uh, depending on the pain, the muscle fiber will align longitudinally, it will heal very well. So you have to, depend if it is a muscle injury, you have to use at least passive range of motion even from day one onward. After the day one, you can start it up isometric contraction. Then once you having achieved that level, you have to go for the full contraction, concentric and the eccentric. Careful about the eccentric. Eccentric is the one is important as well as causing more damage. Pain management, very important. We usually prescribe painkiller NSAIDs for 1 week or more than that. In our practice, we are giving it is only up to 3 days because NSAID is reducing your healing capacity in the muscle. So you have to reduce giving up to we are giving 3 days to just to improve their tolerance, the main tolerance of the pain and encourage to movement only. Then we have to use the physiotherapy modalities like the TENS. If it is with if times goes, you can use ultrasound therapy and you can ask your physiotherapist to give the recommendations. Right, time for healing. This is the time that I'm putting here is just a guide. It is not the perfect one, so you can have an idea. So if somebody is having a type grade 1 hamstring injury, usually 10 days to 14 days it will be healed. If it is a grade 2, it will take 3 to 4 weeks. If it is a grade 3 injury with involvement of the central tendon, maybe take 3 months. So it's very important to identify which grade he is in. So how to identify that one? First thing is, if hamstring injury player after 2 weeks, after 2 days still limping, that means healing take a long time. If it is settling within 2 days time, he's having a good chance of coming back very quickly. Right. Never do ultrasound scan at the acute stage, because if you do it on the acute stage, you will see only a blood clot. So you can't see how much gap, how the area of injury and everything. So better to just delay it at least for 10 days to just to healing up this blood clot, and you can have the idea of having good the ultrasound imaging. Or else you can do MRI. MRI is very expensive, so unless for few athletes, we are not recommended to do the MRI. But in the developed countries, all the return to play and the decision and everything taken with the MRI, but we have to manage according to the clinically and the available resources. Right. Okay. Now I'm moving into the knee injury, and knee is the one of the important thing in the rugby. Like other joints, we will talk about. I will mainly talk about the anterior cruciate ligament injury. Other things like MCL injury, lateral collateral ligament injury, and the meniscal injury. Initial management is bit same. So if there's anything difference, I will inform. And mainly I will focus on anterior cruciate ligament injury. Right. What is it? Why it is so important? What's the reason for this? The reason is this is the only ligament in our body, not the important ligament, that is intra-articular extrasynovial, right? Uh, so, and also it's having the gravity. So it's contacting femur and the tibia. As you can see in this slide, it is prevent tibial anterior translation. It gives rotational stability. It's giving forces to prevent a valgus and the varus movement and the knee proprioception. If when the ACL going, all these are disrupted. That's why ACL is more important. There's a discussion happening in between the in the medical field and in the physiotherapy side as well. Healing of the ACL. So there are some say it is healing, some are not, but still we are believing it is healing is less kind of a ligaments. Right. How are they present? Uh, Initially you can't identify whether it is a ACL injury or not. He will have in the pivot position like the what you can see in this picture. We we call it like the no return position. Like once you go there, it is stuck. So because of this force, the ACL is getting damaged. Usually, it is an indirect injury, to 80% because of the indirect injury. He will present to you with acute swelling. Right. Acute swelling, differential diagnosis of the somebody comes with the knee injury with acute swelling are ACL injury, MCL injury. Other thing is any kind of a fracture. Then it may comes with a pop sound, right? Important thing is he may be not able to continue his play. Once you're having a full tear of ACL, usually you can't get up and continue the play. He will be stay in the ground. If he's this is not the norm, like this is just the idea. So if it is full tear, you can't get up and play. If it is the grade 1 or 2, you may be able to. Right. And please consider about the other associated injuries as well. So how to manage price protocol? Please, if there's a knee swelling, please take the X-ray and exclude any fractures. Once you exclude the fracture, you have to do not let him to have full weight bearing, usually at least the partial weight bearing with the clutches. And you have to put the bandage or the knee braces, ask him to put the ice and do the elevation during the lying down position. And please review him after 3-4 days. You may, because of the muscle contraction, you may not able to see ACL clearly with the anterior drawer test or the Latchman test. So ask them to come in 3-4 days time. Initial time, please do not try to aspirate blood. After 3-4 days, once they come, you can try to reduce, do the blood aspiration, because if there is a blood in the knee joint, it will be inhibit your quadriceps muscle and everything. So we want to prevent that. It is not smart, depending on the condition, right? Once sometimes, and also you can do the ultrasound scan, but only thing you can see is the effusion. You can see the ACL ligament. Ideal one is the MRI, but better to wait till at least for 10 days to 2 weeks just to settle down the blood. Then you can have a good visualization of the ACL ligament. Right. Management. Right. So according to the books, after ACL injury, either you have to go for the ACL reconstruction. Sometimes the ACL is like that. We divide in the society into 3. First part, even without ACL, they will manage. We have seen some players, we identify he is having a ACL injury when we are checking for something else. And that is still, they were playing very well without ACL. Right. Some 1/3 in the society is there, they need ACL. But if the ACL gone, you have to do the surgery. There's no any other option. The mid 1/3, if you do the proper rehabilitation, he may not need the ACL surgery, right? So that is how we are dividing. But as a rule, like the pivoting sport, like the rugby and the hockey and the football, in the pivoting sport, very difficult to survive without the ACL. So with the time, we have to go for do the surgery. Usually, we have to do the prehabilitation uh, exercises to keep the quadriceps muscle strengthening to have a good outcome. After the surgery, we have to uh, more focus on hamstring muscle than the quadriceps for the rehabilitation process. Usually, it will take around 9 to 12 months to come to the ground, but there are miracles. Like, as you know, the South African captain, Sia Kolisi, had the ACL injury, and he will come to World Cup within 4 months. He play all the matches, won the World Cup as well. Still no one knows how they did it and how he comes out from there. Those are they are not keep with them, right? So other thing is the ankle injury. Because of the time constraint, I will go a little bit quickly. So we have to first thing is the lateral collateral ligament and the medial collateral ligament. We have to see for the syndesmotic injury and the Lisfranc injury. I will talk about the lateral collateral ligament injury. Right. So lateral collateral ligament having ATFL ligament, CFL ligament, and a PTFL ligament. Out of these, PTFL is a very strong ligament. Is usually, unless there's a knee dislocation, it won't be damaged. So weakest one is ATFL ligament and the CFL ligament. So grading is happening according to these two ligaments. The partial tear of ATFL is we consider grade 1. If it is a full tear with ATFL, grade 2. Grade 3 is a full ATFL and the CFL ligament tear. Right. How they present to you? The mechanism of injury is the plantar flexion and the inversion injury. The with the it having the swelling over the lateral side of the ankle and the blood will be draw like the picture I have showing in here. Right. So he will comes to you, but if he's not having any limping, maybe the grade 1. If he's having a limping, you have to see whether it is grade 1, can't be the grade 1, so it is 2. If we can't walk at all, maybe grade 3. Right. You have to look for the tenderness in the ATFL ligaments as shown in this picture, and look for the associated injuries like syndesmotic injuries or any fractures. Right. Special test we are using for checking lateral collateral ligament is the anterior dover test for the ankle. Right. I have given the question similar to like this as well in the question section. So investigation, we are using X-rays if it is positive with the Ottawa ankle rule. Otherwise, you don't need to do that. Good ultrasound scan will be give you a very good idea of ATFL and the lateral ligaments injury. If is lateral ligament injury and the is associated or having a separate medial collateral ligament injury, the deltoid, the healing time is very much delayed because the deltoid injury, medial collateral ligament, is one of the strongest ligament in the body. So if it is damaged, means high energy involving injury, so it will take a lot of time to settle it down. So manage like I saw basic first, the price protocol, pain management. This is the ligament. Do not give uh, for more than 3-4 days, and there is a swelling. For the swelling, you can don't use the fusamide kind of a thing because it is banned in the sport. You can use ceratopeptidase to reduce the swelling, and use the ankle brace, not the ankle sleeve. That is the misconception that we have. The one in the left side is the ankle sleeve. It is only give the proprioception, not giving any strength to the ligament. If you're giving a brace for the ankle, please use in the ankle brace showing in the right side, which is we are putting the lacing and the strapping, right? bit expensive, but no point of using ankle sleeve for the ankle injuries. Right. Problem with the ankle injuries in the lateral ligament is same like in the hamstring. It is having a high recurrence rate. So if it is a grade 1, usually it will settling in the 7 to 10 days. And in the grade 2, usually in 21 days. Grade 3, maybe 6 weeks. If it is not, then you have to go for the surgical interventions. Right. So during the practices, you have to use the ankle brace at least for 6 months to prevent recurrent ankle injuries. Right. So I will move to the neck injuries. First one is tinge and burn. It means when you play, you will have sudden nerve irritation, pain, and burning pain radiating up to the fingers, maybe bilateral or the unilateral, usually the unilateral. Maybe having the weakness at that time and the numbness. It may, within 1 minute, it will be settled down usually. Right. If it is not, it is atypical, right? Right. I will mention how to tackle this condition. If it is completely resolved, yes, you can ask him to play. If you have another one during that match, please take him out and do the investigation. If we have in the first, third one, during the same season, you have to thoroughly investigate whether there is any brachial plexus or nerve root injury. The pain because of the nerve irritation, unless proven otherwise, having the brachial plexus injury. So you cannot miss that. If somebody is having bilateral stinger burner sensation goes on your arms, within 1 minute it is settled, but not like in the unilateral. Bilateral, you always suspicious about spinal cord injury. Sometimes you may have to even to check for the MRI, depending on the resource availability, you have to thoroughly investigate. Right, the back injury, it's very big topics, right? I'm sorry, I cannot take more times to give details onto this. And back injuries are mainly usually happen during the pre-season time uh, gym sessions, because we are progressively increasing their strength, then this problem is coming. Usually they will have the disc injuries, muscle spasm, and the stress fractures. Past fractures are very much bit rare, bit less compared to the pivoting and other, but it is there. Main thing that we see is the spondylolisthesis, because of the weight maldistribution in the technical part. If somebody is having a spondylolisthesis, don't worry. If he doesn't have any neurological weakness or any other symptoms, with the proper rehabilitation, he can come back to the normal level. Even in our field, I have seen even with type 2 level, they are playing in the even in the international level. So not we are not treating only with to the X-ray. We are treating to the clinical condition. Um, right. Okay. How to manage the back injury? Exclude red flag sign. If somebody is having the red flag sign, don't take any risk. You have to refer to the specialist and settle it down, please. And investigation, we are taking the X-rays and the CTs and MRI depending on the condition, but don't overdo it, because these players are the ones who are lifting weights for years and the decades. He will have so much of abnormalities when you do the MRI, right? So because of that, please consider about it. Don't do unnecessary investigation. Uh, you can't come to the conclusion otherwise, right? Same thing like the RISE protocol, physiotherapy. You can give painkillers and you can give a muscle relaxant. Muscle relaxant, especially we are using tisonidine or the baclofen. If you are prescribing muscle relaxant, please ask him to have a rest, because with the muscle relaxant, never send him to the ground, because they feel weakness in the muscle, sogginess, it will cause more damage. So when you are prescribing muscle relaxant, please avoid to play contact session and the lifting part. Right. Okay. I think I have within 1 hour duration, I have finished my lecture. Then I will go for the question that we had on the pre-sessions, right? First one, please mark the correct answers regarding the rugby. More injuries occur at the professional level than the lower level. No, injuries are less in professional level compared to the lower level. Rugby is a contact and the combat sport. Yes, it is a combat sport. So that is why we're having more injuries. Third one, all players possess similar strength, power, agility. That is wrong because I told you this is a beautiful game. Having you can various body type people are there to the uh, particular function to be done. So they have different strength, different power, different agilities. This is the one I want to mention, and there is a specific age limit to play as a front row player. Yes. So usual thing is up to 18 years, players are not allowed to play at the highest national level, not the age group, highest national level. They have to be over 80 years, and in the school level, uh, front rowers like the tight head prop and the loose head prop cannot be played by the under 16 player, right? And in the front pack, you can add it under 16 two players only, but they can't play as a props. So what I mentioned here is most of the time when the season is starting, lot of school will comes to your private practice or in the hospital and the clinic can ask to just to give the clearance letter to play this player. Please read it and see you are giving the uh, correct information and you are pretty much sure about what they are doing, because sometimes they will take the signature from you and say, look, the doctor is giving the signature, that's why we are asked to play, right? So be careful about it. If there's any problem like that, please contact sports medicine unit around the country and take their opinion as well. Right. Rugby is a moderately dynamic and a moderately static game. Yes, I told you. They are putting it like that, but the dynamical and the static part is getting increased every year. Regarding the concussion, classified as a mild traumatic brain injury, yes, it is. We are categorized as mild traumatic brain injury. Not considered a significant injury, wrong. It is a significant one because there's a thing called second concussion syndrome. It means once the concussion is there, if you allow him to play before uh, settling down the symptom, the outcome will be pretty much bad. So please consider about that one as well. A player must be rest for at least 1 week. No, rest is for 1 day. Other times he has to engage in graded rehabilitation process. The player can participate in matches within 3 weeks. Yeah, I told you that within 3 weeks, yes, adult and children they can play if they pass through go through that rehabilitation process. It is advisable to keep the player out of the school until full recovery. That is the wrong message. Player supposed to go to school before play the rugby, right? If he is not going to the school, means he is not fit enough, because this is something about the cognition. So cognition is mainly improved during the school. So once the symptoms are subsiding, encourage them to go to school. So you can give a letter to the class teacher. He's had the concussion. He's having these symptoms. He may not be able to concentrate for the 40 minutes of the school time. So please consider uh, changing the environment 20 minutes and give the rest, something like that. So you have to manage it. Right. Then about the acromioclavicular joint injury, classify according to Rockwood classification. Yes, I said it is 1 to 6, and we are concerned more about 1 to 3. Players may need to protective padding to prevent re-injury. Yes, you have to use the protective padding that I showed in the previous slide, or the taping like showing in this picture. High-grade injuries always require surgical correction. No, depending on the condition, we are deciding whether he need it or not. A disfigured AC joint is an indication for surgery. Some you may not understand this question. The reason is when you play for the rugby for years in the front, especially the flanker, second rowers, they will have elevated AC joint one side or the other side. They have malalignment through their lifetime. That doesn't mean you have to fix it. That is normal in rugby. Right? That's what I want to mention. Then return to play decision depending on the player's position. Yes, right. So if he's a jumper and he need more time to recover, if he's not a jumper, he's just playing on the side. You can come without. If he's not a contact person like the back row, the wings, so we don't need much rehabilitation process. If it's a contact play only, we need more rehabilitation time to come to the ground. Next one is about the ankle injuries. Lateral collateral ligament injuries are the most common. Yes, it is one of the commonest in all rugby injuries. Return to play time is delays when the medial collateral ligament is damaged. Yes, I told you medial collateral is the one of the uh, hardest ligament. So if it goes means you need more time. Ankle X-ray should always be obtained. No, according to the Ottawa ankle rule, we have to take the X-ray. Grade 2 lateral collateral ligament injuries may require 3 weeks to return to play. Yes, I told you. Grade 1, 7 to 10 days. Grade 2, 3 weeks. Grade 3, maybe more time. This is just an idea, right? This is not the gospel truth. Like it depends on the player, but with these numbers, you can have idea. With proper rehabilitation, the risk of re-injury is reduced. Yes, right. If you have not having the proper rehabilitation, injury risk is high because lateral collateral ligament is the one controlling most our proprioception. When the ligament is gone, our body proprioception is reduced. So we are more concentration on rehabilitation on proprioception improvement in the ankle. Right. Regarding back and neck injuries, bilateral tingling sensation in the arms that resolves spontaneously do not require further investigation. I said, if it is bilateral, whether it is resolved, you have to, it is not the normal sting and burner. You have to investigate to exclude if there's any spinal level problem. Grade 1 spondylolisthesis is a contraindication to playing rugby. No, if he doesn't have any symptoms, if he's having the good no is not painful and he's lifting very well, he can continue playing. Pars interarticularis fractures are not seen in rugby players. Wrong. That is more common in cricket kind of a bowling action games, but you can see it in the rugby because rugby also having the kicking part. When there is a kicking part involved, interarticularis can damage. Players can use muscle relaxant during the training session. I would avoid that because it will reduce your muscle tone, so it may cause more damage. So at least for 2 3 days, please avoid and give the instruction. Straight spine on X-ray due to muscle spasm require aggressive treatment. It is like this. If he complain about the back pain, when you take the X-ray, the straight spine, then you have to act. But for the something else, when you take the X-ray and you will see the straight spine, do not worry much because these players are lifting a heavy, high load like of weights and tackling and scrum and collision. So they may have, as a protection, they may have this spasm, right? If it is painful, yes, you have to address. If it is not, don't go for aggressive treatment. You can do manual therapy, relaxation, the stretching, those kind of thing, and see how it is. Okay, I think I have finished during my allocated time. If there is any questions or anything, I would happy to answer. Thank you very much.
Thank you, sir. We have a couple of questions which have come up on the chat function. The first one is, what are open and closed chain injuries?
Um, Not the injuries, actually the exercises. I think
Yeah.
maybe I think right. Close chain is you if you take the bicep curl, right? Your bicep, your bar is on your hand. It is the one is moving up and down. So your distal part is moving freely. That is open chain exercises. Open chain exercises is good for particular kind of a muscle, but we are prescribing more closed chain. Closed chain is think we are doing the squat. Our distal part is ankle. So ankle is not moving; it is on the floor. All the other parts are moving. That is the closed chain. So bench when you take the bench press, it is it's not the open chain, but it is in between open and closed chain, right? So deadlift, that is the closed chain. All the time, if you are doing any exercise, as you know, if we are doing any exercises, please try to do closed chain exercises. Like if you do, shall we take uh, the simple is bicep curl is the open chain, wrist curl kind of a thing also, tricep and everything is open chain. Multiple complex joint involving deadlift, squat and pull-ups, chin-ups, everything is closed chain exercise. Closed chain exercise is good for the body, not the open chain exercise.
And one more question, sir. This has come up a couple of times. What are the advices that we can give rugby players to prevent head injuries during matches?
Yeah. First thing is the good technique. First thing is the always about the technique. You should have a good coach's opinion and the guidance to have a good technique. And you can use head scrum, but scrum and the then our mouth guard, right? The thing is, it even though we are using the scrum cap or the mouth guard, it won't reduce the concussion rate. The reason is when you having the scrum cap and the mouth guard, they think they are invisible and they are go for more risky contacts and everything. So because of that, it not reducing contact. So always about the technique, right? And you have to know how to protect your head, right? Always use the mouth guard to prevent dental injuries, and if you can wear the scrum cap, that would be better. But it's
Like
like this when we are when we are driving the car. So if you may be a good driver, but the ones who coming in front of you is not a good driver, there will be a collision. So even though you are having a good techniques, the opponents is not having the good techniques, there's a risk. So that's why. So there's a risk all the time.
yes, sir. I think because we are running a bit on out of time, we will wrap up the session with that question. And if you do have any other specific questions that you would like answered and you couldn't ask during the session, you can of course email us uh, to the email address which was mentioned at the beginning, and we'll try to get your answers delivered to you. We thank Dr. Rangana Hettige, a consultant, sports and exercise medicine physician at Teaching Hospital Peradeniya, for his excellent lecture and answering those questions and dedicating his valuable and precious time for this event. Thank you, sir.